All right, up next is the integumentary system, aka our skin. So we all know that the integument, we have lots of diseases, and basically half of the people that you're going to be seeing in the primary care setting are going to come in with skin complaints because nobody likes skin issues, right? Ugh. But we have benign diseases like acne, or we have severe life-threatening diseases such as malignant melanoma. So understanding the basics of the integumentary system is very important, since this is going to be a large portion of the patients that you're going to see. So remember that our body's largest organ is the skin, the integumentary organ, and it represents about 16% of our body weight, and it's about 20 square feet, so it is quite large. And it is basically our barrier to the outside world. As we talked in immunology, it is that physical barrier that really creates that first level of defense against invaders. So very, very important. It's also really important to prevent fluid loss. We know when patients get severe burns that their system is really upset and allows for a lot of fluid leakage. Other things, it really helps with temperature control and regulation, secretion and absorption, vitamin D production, immunologic surveillance, like we just talked about with that first physical layer in the immune system. And there's multiple layers to the integument that we're going to go over so that you understand. So the skin is formed by two major layers. The first layer is the superficial or outer layer, which is considered the epidermis. And then the second layer is the deeper layer, which is the dermis, which is considered the true skin. We also have what is considered the subcutaneous layer, which we call the hypodermis. So what else is involved? We have a couple different layers here that you can see represent the epidermis. We also have multiple things in the dermis that we'll go over. So the epidermis contains, basically from top to bottom, we have a couple different layers. So here is going to be the stratum corneum. So that is going to be that outermost layer. Then we have the granular layer, also known as the stratum granulosum. The next layer is going to be the spinous layer, or otherwise known as the stratum spinosum. And then the last layer is the basal layer. Basal means bottom, underlying. Then you're going to get the dermal layer. We also have junctions that happen. You can see here they are much tightly crossed over. We have a lot more tight junctions in those epithelial skins when we're in the stratum corneum and granular layer. The epidermis consists of keratinocytes and Langerhans cells. So remember, we have those macrophages that get named differently when they're in different areas of the body. Langerhans are what we call them when they are in the skin area, but they are basically macrophages. And they're going to really look at dendritic processes and immune functions. Keratinocytes, it is normally very thin, but it can thicken and form corns and calluses with constant pressure or friction, which is what we know happens on the feet a lot. All the way to the granulosum is mainly keratocytes. Once we get into the granulosum, then we do get some melanocytes. When we get into the stratum spinosum, we have newer keratinocyte, and there are those tight junctions that we talked about, those desmosomes. So they're going to create those it's basically like a lattice work, those tight junctions between the epithelial cells. When we talk about the basalis, this is the regenerative stem cell layer. So this is where we're going to get a lot of function from Merkel cells. Sensory nerve endings also could ride in that area. This is the level that it's going to allow for cellular replication and production of those cells. Again, we would have melanocytes in this area, and this is going to be where we're going to have that pigment and melanin, which gives skin the color. So when we go down to the dermis layer, this is where we're going to find the connective tissue, all the nerve endings, blood and lymphatic vessels, and your adnexal structures such as hair shafts, sweat glands, and sebaceous glands. So the dermis is really, again, with macrophages and mast cells. They are going to reside there to also help with making sure that we have that layer of protection. It's going to have rich blood, lymphatic, and nerve supply, and this is going to be where our sensory receptors are and sweat glands. So we have apocrine, eccrine and sebaceous. We also have another form of wandering macrophages, and they are called histiocytes. They are in the dermis layer, however. Remember that your mast cells are going to release histamine and are heavily involved in those signs that we get when we have those allergic reactions. When we talk about the adnexal structures, the nails, they are protective and they are basically keratinized plates, and they appear obviously at the end of our fingers and toes. So the main blood supply is going to be by capillaries. It's easy to remember, right? Capillary. And these capillary loops are supplied by that deeper arterial plexus, and then that branches to the deep plexus. That also is going to supply those hair follicles and sweat glands. We're talking about apocrine and eccrine. So the eccrine are really found more on the palms of the hands, the soles of the feet, and the forehead. And they are really going to open up and important for thermoregulation. Apocrine, we have a lot less of those sweat glands, but they produce much more sweat than the eccrine do. The apocrine, those are located near the hair follicles, the scalp, face, abdomen, and genital area. There's another picture of that, as you can see more from a side view. So when it comes to common complaints of integumentary system, then of course we're going to get rashes and itchy skin, mold changes, maybe an open wound, a cut, a laceration, lesions appear. Pressure ulcers, really anything can happen to the skin to really put it at risk. Workup is really heavily involved on the physical exam and you being able to recognize what the lesions look like, being able to understand all that terminology that you learned back in A and P. I'm not going to spend a lot of time on it, but this would be what's the difference between a macule versus a papule versus a patch and a plaque. All of those are high yield because that's how you're going to be describing what your complaint is related to how the rash is going to present itself. We're going to just take a look at some of these dermatoses. The way that I have them grouped is inflammatory, whether they are going to be a blistering dermatosis or an epithelial tumor. So hopefully that will be to kind of group it in your brain. So for the inflammatory dermatosis, we're going to be looking at atopic dermatitis, which everybody refers to eczema. However, eczema is a really generalized term, which is actually not correct. So it is atopic dermatitis. We're also going to look at contact dermatitis, acne vulgaris, psoriasis, and lichen planus. Familium is a small cyst that contains keratin, which is that skin protein that we talked about in those top layers. And when you get more of them, it's called milia, and they are harmless little tiny pearl-like white bumps just under the skin surface. You have neonatal milia, we have primary milia in children and adults, and then you can also get juvenile milia. Often seen around the nose, but also arise the mouth, the mucosa, also on the soft palate. And they usually heal spontaneously if it's within a few weeks of birth. For children, it may take a couple more weeks or persist for a few months or longer. And then juvenile milia is actually associated with a few syndromes. Miliaria is a common skin disease caused by blockage or inflammation of the eccrine sweat ducts, and that is often seen in hot, humid, tropical climates, patients in the hospital, or in the neonatal period as well. And this is basically what we call heat rash, sweat rash, or prickly heat. This is based on sweat duct obstruction, and we have a couple of different types, but basically understanding that it is related to that blocked duct. Sebaceous hyperplasia is a term for an enlarged sebaceous gland, and that's usually seen on the forehead or the cheeks. And we see this in middle-aged to older patients, and they appear as small yellow bumps, and they're about 3 millimeters in diameter, and then they may reveal a central hair follicle that is surrounded by some yellowish lobules. It is a benign hair follicle tumor. Toxic erythema of the newborn, also known as erythema toxicum or erythema toxicum neonatorium, is a common benign condition seen in newborn infants. It affects about half of all full-term newborns. but it's less common in those born prematurely. No known sex or racial predilection, although it has been under-recognized in infants with darker skin. Basically what this is a combination of erythematous macules, papules, and pustules. And this eruption usually waxes and wanes over a few days, and it's usually on the face and spreads to the trunk and limbs. Palms and soles are usually not affected. This is usually a benign situation and requires no treatment. However, you do need to make sure that you rule out some other things, such as maybe an infection like impetigo or folliculitis, herpes, varicella, histiocytosis, or eosinophilic pustulosis. So there's some other things that you may need to consider. Benign cephalic histiocytosis is one of those things that would also present related to those histiocytes that are in that deeper layer. So histiocytosis is a rare condition, and it is those immune cells that are usually within that epidermis, and they are acting as antigen presenting cells. And what happens is there's an increased reactive number of those, and we get a histiocytosis. All right, moving on to atopic dermatitis. So atopic dermatitis, this is a itchy, erythematous, oozing rash that has vesicles and edema. It often involves the face and flexure surfaces, and it is a type 1 hypersensitivity reaction. We often see it with asthma and allergic rhinitis. We talk about the 3 A's. We usually see these things together. So asthma, allergic rhinitis, and atopic dermatitis. So just remember to associate those together. This is the most common inflammatory skin disease worldwide, and it just presents as dry, itchy skin with a rash. So there is approximately 230 million people that have atopic dermatitis, and the prevalence is about greater than 15% worldwide. So it's pretty big. Typically affects people with atopic tendency, and that's what we're talking about, these asthma and allergic. And it basically means you're one of those allergic people. Like you have allergic asthma issues, you have allergic rhinitis, and then you have some skin issues that are typically related to some allergies. So it usually starts in infancy, affecting about 20% of children, and then they're going to develop it really before age 6. However, all ages can be affected. It can settle down in late childhood and adolescence. Looking at the pathogenesis, so we have epidermal barrier dysfunction, we're looking at gene impairments, skin pH is altered, there is increased allergen susceptibility, we have decreased ceramides, decreased hydration, decreased Staph aureus resistance. Immunologic abnormalities, so then we would have maybe some calcineurin mediated T helper 2 cell activation. We would have interleukin 4, interleukin 13 production, which we know are pro-inflammatory, serum IgE, and then PDE4 activation as well. Aggravating factors, so all of this would create more of a trigger, and that would be dry skin, harsh soaps, detergents, seasonal heat, sweating, infections, and then food allergies as well. I talked about this site before. The Calgary Guide is really amazing with doing these PATHO flow sheets, which I really like. So take a look at this. And as you can see, we have those immune issues, the epidermal area, the adaptive immune system issues, and then altered skin microbiome. And then this is going to lead to all of our presentation signs and symptoms. So take a look at that. And then there's a picture of it. Remember, it's on the flexure surfaces as well as on the cheeks of the infant usually. Ways that you would test for this and your differential would include psoriasis, seborrheic dermatitis, genetic orders such as ichthyanthosis or primary immunodeficiencies. Contact dermatitis is always high on your differential as well. This is really a clinical diagnosis, and you really don't need to do much testing workup wise, as you're going to find with a lot of these skin issues. Seborrheic dermatitis, so this is greasy, scaly, white, yellow, sebaceous areas, and they may be itchy. We do see this usually on the scalp, eyebrows, eyelids, ear canals, axilla. Really, where we have a little bit more concentration of these seborrheic areas. So this is a common chronic inflammation of the skin, and it in infants is known as cradle cap. Really, we don't know why, so we really have no known etiology, but it's an inflammatory reaction to Malassezia yeast has been proposed. And they can happen from infancy to old age, periods of remission and exacerbation, and basically we treat it with topical therapies that include sulfur, salicylic acid, or tar. Contact dermatitis, this would be high on your differential for atopic dermatitis, but this is after an exposure to something. So very high yield with contact dermatitis. You really need to be able to identify, did they get exposed? And when you do your skin workup, you know, those are the first common questions you ask everybody. Did you change anything new detergent wise? Did you come in contact with anything that you've never come in contact with before? So those are always very routine questions that you would ask with any skin issue. So this is a very itchy erythematous oozing rash as well, with vesicles and edema. So you can see why it's in that differential. And this is a non-immunological mediated inflammatory reaction if it's related to irritants. It is a cell-mediated or delayed hypersensitivity if it's related to allergic contact dermatitis. And that's what we see here. Type 4 hypersensitivity irritant would be non-immunological. And then drugs, you can have a reaction related to drug exposure as well. Basically, you remove the offending agent and hopefully some topical glucocorticoids and anti-itch. Irritant contact dermatitis is a direct toxicity without prior sensitization. If it's an allergic contact dermatitis, it's usually related to delayed hypersensitivity, which would mean sensitization. You can see the variances here of what contact dermatitis can look like. All right, so next up is acne vulgaris. And this, of course, is one of the big things that you're going to see in our teenage population. So this is an inflammatory disorder of the pilosebaceous follicles. And that's the sebaceous gland that has a hair follicle within it. And it usually occurs during adolescence because it is highly impacted related to hormones. And that's why we see it get worse when children grow into the teenage years and hit puberty. So this affects about 85% of the population between age 12 and 25. So what you have is non-inflammatory and inflammatory. So there is chronic inflammation of the hair follicles and the sebaceous glands. And then we have the Propionibacterium acnes, which is the infection, and that produces lipase that breaks down the sebum, and that releases pro-inflammatory fatty acids, and that's where we get the pustules or nodules formed. The non-inflammatory acne, those are the comedones, and those are your open comedones, which are blackheads, and closed, which are whiteheads. They are accumulated material causing distension of that follicle and then thinning of the follicular lines. You can have both types. Acne rosacea, so this is flushing, dilated, prominent telangiectasias of the face. This is really going to be present on the nose and the cheek area as well as the chin. And it's a prominence of those sebaceous glands. And it can result in what we call rhinophyma, which is a fibrosis related to those sebaceous glands. We really don't know why. Factors that do trigger it are known to include climatic exposures, vasculature issues, chemical and ingested agents, and inflammation. Psoriasis, so this is a well-circumscribed salmon-colored plaque with a silvery scale, and it's usually in the extensor surfaces and also the scalp. You can also see pitting within the nails, and this is related to excessive keratinocyte proliferation. It is possibly an autoimmune association, not exactly sure, and it's related to the HLA genetics, and they also often arise in areas of environmental trigger trauma. And what happens is we see this epidermal hyperplasia, hyperkeratosis, more neutrophils in the strata corneum, And then we get a thinning of the epidermis resulting in bleeding when picked. That is called the Auspitz sign. So when you scratch open the area and it starts bleeding, that is called an Auspitz. Usually we give IV UV light or immune modulators to help. Here are some pictures of it. And then there's the pitting on the nails that you would see. Pityriasis rosacea. So this is an acute self-limited inflammatory eruption. Single layered lesion, which we call the Herald patch. So that's what that is right there. And then you can see some smaller patches around it. That's those smaller oval lesions. This is an inflammatory skin condition. They're really not sure why or who it happens to. It just kind of shows up. It's really benign, it's self-limiting, and does not cause any problems. Lichen planus, so this is an itchy, shiny, flat-topped, violaceous papule and plaques. Likes to favor the extremities. So we call this the 5 Ps. You're going to have planar, polygonal, purple papules, and they're pruritic, okay? And we see white lines on the surface, and we call those Wickham striae. You really see the Wickham striae with oral involvement. What happens on histology is there is a classic sawtooth appearance on it. Don't know exactly why this happens either. It's likely related to an immune response. It's also associated with hepatitis C. And they think there is T lymphocytes that are getting into the dermal epidermal junctions and inducing apoptosis of the basal keratinocytes. Next up is blistering dermatosis. We're going to take a look at pemphigus vulgaris, bullous pemphigoid, dermatitis herpetiformis, and erythema multiforme. So pemphigus vulgaris, this is a skin and oral mucosa bullae issue. So we have acantholysis, which is a separation of that stratum spinosum keratinocytes, resulting in suprabasal blisters. So if you refer back to our levels, we have that basal level and then the spinal level. So when we're talking about these blistering dermosis, we usually have a separation. So the basal layers remain attached, but the next layer basically creates this bulla, this area that the blister can form. This is a thin-walled bulla. It ruptures very easily, and that is called the Nikolsky sign. So if you would touch it, it would pop very easily. And that's because of the layer that it's at, the stratum spinosum, resulting in those suprabasal blisters. This is related to autoimmune destruction of those desmosomes between the keratinocytes, and this is a type 2 hypersensitivity. Bullous pemphigoid, so this is kind of that same blistering dermatosis. This happens in much older patients, usually around 80 or older, but can affect patients around 50. Also can occur in younger adults and infants, but it's very rare. So this is blistering of the skin, not usually in the oral mucosa. So that's one of the ways you're going to differentiate between pemphigus vulgaris versus bullous pemphigoid. Also, they are symmetric and favor the flexural aspects of the extremities, lower trunk, and the abdomen. If you remember, the other one was the oral mucosal scalp and upper body. So there is an association related to autoimmune destruction, IgG again, antibody against the hemidesmosome components of the basal cell and underlying basement membrane. Now these are very tense bullae and they do not rupture easily. So they would not have a Nikolsky sign because they would not pop very easily. And that's related to the location of where the blister is developing because it's underlying the basement membrane. So erythema multiforme, this is an immune-mediated targetoid rash and bullae. It has that central epidermal necrosis surrounded by erythema. You can see a couple different skin tones here to see what it would look like. So this is usually precipitated by a virus such as herpes. Alternate triggers would include other medications, some drugs, vaccinations. Also can be autoimmune or related to some malignancy. This is a distinct entity from Stevens-Johnson syndrome and toxic epidermal necrolysis. This affects really only about 1% of the population, and it's very common in young adults. It does have a more predominance with male population. If you have erythema multiforme and it has fever, mucosal lip involvement, then you're getting into Stevens-Johnson syndrome. They are two distinct entities, but they look the same. And one of the ways that you would differentiate that is that erythema multiforme is not going to involve oral mucosal or lip involvement. Toxic epidermal necrolysis is a severe form of Stevens-Johnson syndrome. So those are kind of all TEN and SJS are on the same spectrum. Next up, we'll take a look at epithelial tumors. So seborrheic keratosis, these are benign proliferations of basal cells that produce flat or slightly elevated lesions. They may be smooth or they may appear more warty in appearance. Really don't know why this happens. Pathogenesis is unknown, and they are seen in older people and occur as lesions on the chest, back, and face. Can vary anywhere from tan to waxy, flesh, dark brown, black. They may vary in size from a few millimeters all the way to several centimeters. They are often oval and greasy appearing, related to their hyperkeratotic scale. They are benign. There is a sudden onset of multiple keratosis called lesser treelet sign, and that is this down here. If this happens, suggests that there is an underlying gastrointestinal carcinoma if you see a whole bunch of seborrheic keratosis present themselves on the patient. Acanthus nigricans. So this is epidermal hyperplasia, and this is that velvet-like skin change, often in areas of the folds, axilla, the groin, the neck. It's associated with insulin resistance or malignancy. You can see it with malignancy, so it's just something to be aware of. Where we most see it is with diabetic patients. You can see this early on in insulin resistance, and that helps you with diagnosis of diabetes. Basal cell carcinoma, so this is an elevated nodule with central ulcerated crater, and it's surrounded by dilated vessels, telangiectatic, and we call it a pink pearl-like papule. As you can see here, that's what it looks like. This is a basal cell proliferation. It is malignant, and it is the most common cutaneous malignancy. Metastasis is rare. It's related to UVB damage. Treatment is cutting it out. The other version of skin cancer is squamous cell carcinoma. So this is more of an ulcerated nodular mass. It's usually on the face. It classically involves the lower lip. If it involves the upper lip, it's actually more prognostic of having more severe disease, which is very interesting. So this is malignant proliferation of the squamous cell with the formation of keratin pearls. Again, related to UVB damage, immunosuppressive therapy, arsenic exposure. Actinic keratosis is a precursor lesion, and that presents as a hyperkeratotic scaly plaque, often on the face, back, or neck. Again, treatment is excision, and metastasis is extremely rare. When we look at disorders of pigmentation and the melanocytes, we're going to be just taking a quick look. Vitiligo, albinism. Vitiligo is related to autoimmune destruction of the melanocytes. So you're going to see this with autoimmune diseases usually. Albinism is a congenital lack of pigmentation, and it basically impairs melanocyte production. Freckles and melasma, so freckles, small tan black macules, they get more when they're exposed to sun, and they are just increased numbers of melanosomes, not melanocytes. Melasma is that hyperpigmentation that is associated with pregnancy and also oral contraceptive pills. Nevus, these are what we refer to as moles. They also can have wide range of characteristics. They can be flat, they can be raised papules, but they should be less than 6 centimeters diameters. They are a benign neoplasm of the melanocytes. They can be congenital, and they are often associated with a hair follicle. So that's another high yield thing. When we see cancer, we usually do not see a hair follicle involved. They begin as a nest of melanocytes at that dermal epidermal junction, and then they grow by extension into the dermis. Dysplasia sometimes, and that may arise from the precursor to melanoma, and then that would be called a dysplastic nevus. And that is why we always say that you do need to watch your moles, because if they do end up changing size, their texture, their symmetry, then that is all problematic, all right? Because then that may be that we're progressing to a melanoma, because they are melanocytes. So when we talk about melanoma, obviously this is the really bad skin cancer. This is malignant proliferation of those melanocytes. It is the most common cause of death from skin cancer. If you're going to die from skin cancer, it's going to be melanoma. So we look at growth with ABCD, where we're looking at asymmetry, borders are irregular, color is not uniform, and diameter is greater than 6 millimeters. We do have two growth phases. Radial growth means it's horizontal along that dermis and superficial dermis, which means that it's very low risk for metastasis at that stage. Then we have vertical growth, which is going to go down into the deep dermis, and then this is increased risk of metastasis because we're getting near the blood supply, right? The dermis holds the blood supply. This is called Breslow thickness, and this is the most important factor in determining if we're going to have metastasis. So when we're talking about that melanoma, this is what we mean. So we have radial growth, which is going to be more horizontal, and then we have deep growth, which is getting down into that vascular system, and then we're going to have spread. There are a couple of different variants of melanoma. I just want you to be aware of them. So the bad one is the nodular, and this is very early vertical growth. So we're going to go right to vertical growth, which means it's going to metastasize very quickly. That has a very poor prognosis. So understand that nodular is the one that we don't want to really see. Otherwise, most of these do have better prognosis, and they have more of that superficial spreading or more radial growth. Quickly, for infectious disorders, obviously we are going to have some form of infection. Pretty much with all of them, I will put on here. Please review them so that you know what the cause of the infections are. Let's talk about herpes simplex. You have two types. You have herpes simplex 1 and you have herpes simplex 2. They each can cause oral, genital, or ocular ulcers. Many people have unrecognized disease. Either type can occur in different parts of the body, and that includes, so usually we used to say HSV1 meant oral, HSV2 meant genital. However, you can have HSV2 oral and HSV genital. So it doesn't necessarily mean that they are restricted to that area. These are those cold sore or fever blisters that you see. That is HSV1. You also can see HSV1 in the cornea, called herpes keratitis. In the mouth, it's called gingivostomatitis, and in the lips, it's called aureolabal. But it also can cause genital herpes. And then this is transmitted via contact with infected saliva. Again, a lot of times people do not know they have disease and are able to have viral shedding and pass it along before they ever have an episode. A lot more of that happens with HSV1. If HSV2 presents, usually HSV2 presents in a pretty severe manner, and the primary episode is quite problematic. Also, what happens with either one of these is that the virus, after that initial infection, is embedded in the sensory nerve endings, and it moves by retrograde axonal transport to the dorsal root ganglion. And that is going to develop a lifelong dormancy period and gets reactivated in times of stress. Also, exposure to ultraviolet light, skin irritation, fevers, fatigue can activate it as well. So the genital infections are more commonly caused by HSV2, and that's skin-to-skin mucosal membrane contact during viral shedding. So risk of this is very high in immunosuppressed persons or anybody who has sexual contact with infected individuals. There is also vertical transmission from mother to neonate, and that is actually associated with significant neonatal mortality. So both of these create lesions. They begin as small vesicles and then they progress to ulcerations. So there is what they would, and they have that clumping, and then they open up. There's also burning, tingling, some weird kind of more neuro symptoms that present with it, and that kind of is a prodrome knowing that you are going to have an eruption. Then within 3 to 4 days, they ulcerate, that they weep. They can be quite painful. When we're talking about the genital, just imagine if they are in the vaginal canal or on top of the penis. With the pain, the itching, and they're very uncomfortable, it could be quite problematic. So varicella zoster, so this is herpes zoster, which is shingles, and varicella, which is chicken pox. So this is typically going to present with fever, malaise, and widespread vesicular and pruritic rashes, primarily on the torso and the face, talking about chicken pox right now. Usually presents in childhood, usually self-limited. The disease progresses, lesions will scab over, then you get some new peripheral, and that has these different stages of healing. Adult, pregnant women, immunosuppressed patients, and neonates are highest risk of complications, and you can see those complications there. And there's those classic pictures. So that varicella occurs as the primary infection, and then activated later causes herpes zoster, which is shingles. And again, because it is a herpes virus, they like to remain latent in the trigeminal and dorsal root ganglia. Also have those prodromal kind of pain and paresthesias. And then with herpes zoster, when we get into shingles, it follows the dermatome. Next up are fungal infections, what we call tinea. So these are superficial fungal infections, and they are from the dermatophytes, which are the overall species classification, and they will vary with their name depending on the site. So they are spread by direct contact with people, contact sports, animals can be vectors, soil, and then also fomites. So we have a couple different names, just be aware of them. So tinea inguinum is nails, pedis is athlete's foot, capitis is head, crurus is groin or jock itch is the other name. There are a couple other ones. The other thing to make note is that tinea of the toenails does have a special name called onychomycosis. What increases the risk of getting these fungal infections, not only from the direct contact, is host factors such as sweaty, hot, humid climates, tropical areas, also sweaty, moist areas like between the groin, which is where we get the jock itch. If there is pendulous abdomen, we have that pannus. Those are all areas where fungal infections can flourish. Occupational exposures, just really related to are you having contact with animals and soil and things like that that would put you at risk for the fungal infections. Usually this is diagnosed by visual inspection and a clinical, but you can take scrapings if you need. And then you would put them under microscopy, and you would use potassium hydroxide, and then you would see hyphae, which is these branching rod-shaped filaments, and that would be characteristic. But usually we do diagnose related to vision. So this is candidiasis. This is the main one, is C. albicans. There are more than 160 species, however, only about 20 really cause infections in humans, and the number one is that Candida albicans. So candidiasis is normal microbiota that is found in the gastrointestinal tract, in the GU tract, especially vaginal canal, but it does have the ability to invade, and we can get yeast infections really mucous membranes, vaginal canal, into the stomach, as well as up the esophagus, thrush is obviously a common one that we see, and it is also a local overgrowth, and they are very opportunistic. So those risk factors would include patients that are immunosuppressed, or they have hematologic malignancies on chemotherapy. ICU patients are also at a big risk. And then one of the biggest risks are those transplant patients. So this is also diagnosed usually by clinical, but you can also do a culture and a scraping. And culture is actually very important if you are suspecting candidemia, which would be a systemic candidiasis infection in the blood. You would also see these microabscesses and budding hyphae and pseudohyphae when you are looking at it on microscopy. If you are suspecting that you have a systemic yeast infection, then blood cultures would be indicated. You can really get this in the oropharyngeal, esophagitis, vulvovaginitis. For men, it would be balanitis, which would be the white patches that would be on the penis to start, and then can spread to thigh, gluteal folds, buttocks, and scrotum. Also, you could have a mastitis, and this would be related to injured nipples for lactating women. For both fungal and yeast infections, we do prescribe an antifungal, anti-yeast. Usually that will clear it up if it is superficial. If it's systemic, then obviously we would be doing more IV based. Quickly with burns, so take a look. Thermal, non-thermal, inhalation, radiation, electrical. Burn wound depth and classification. So this is something that you need to know. As an emergency room nurse, we had to know this. So it's something that I've known for many years. Boards does like to go after it. Even though you're in primary care, you still need to be able to understand first, second, partial, fourth degree, as well as the rule of nines. So I put here just a quick picture of the rule of nines. It should also be in your book. If it's not in your book, then all you have to do is Google it and you'll get the rule of nines. Basically, we'll classify the extent of body surface, and then to determine the depth and severity, you have to understand if it's first degree, second degree, partial thickness. So here are some also key points related to burns. If there's greater than 40% of total burn surface area or total body surface area, it is considered major and would lead to evaporative water loss, loss of plasma protein, fluid shifts, and it's called burn shock. That is why major burns must go to a specialized unit. It's going to manifest as hypovolemia, hypotension, generalized edema, and of course is life-threatening. Also, what would happen is an increased risk of DIC because you go into a hypercoagulable state related to your body trying to stop the damage that's being done. So you have increased capillary permeability for the first 24 hours, altered cell membrane permeability, decreased cardiac contractility, and decreased cardiac output. Fluid and protein move out of the vascular space and lead to profound hypovolemic shock. Frost nip and frostbite. So this is injury via extreme cold. Looks at affecting those extremities because they're the farther apart. And frost nip is basically no tissue injury after rewarming. Frostbite has ice crystals, direct injury from the cold, and we get endothelial damage. And that's it for integumentary. Obviously, we did not cover every skin condition that's possible, but we covered a couple just to take a look at kind of the differences, and hopefully you'll be able to classify them a little bit in your brain differently.